All right, let's unpack this. Today, we're doing a deep dive into a specific medical condition that definitely pops up in revision for exams like the MSRA, Kaposi sarcoma.
Yeah, think of this as a high-yield audio session. We're basically pulling out the key info you've gathered, the most important bits, to help you really get a handle on the essentials, make it stick.
Exactly. We're going to break it down, start with the basics, what it is, and go right through to management, prognosis, all the crucial points you need.
We'll keep it clear, structured, but hopefully it'll feel more like a chat
Yeah.
than just reading notes.
Right. So let's kick off right at the start. Kaposi sarcoma. Fundamentally, what is it?
Okay, so at its core, it's considered a rare cancer. It starts in the cells that line blood vessels and lymphatic vessels, those endothelial cells.
Okay, so the vessel walls, basically, those cells start growing abnormally.
That's it. You get this abnormal cell growth, and that leads to tumors, lesions forming. We often see them on the skin, mucous membranes, like inside the mouth, genitals. But, and this is crucial, they can also pop up in internal organs too.
And what's driving this? Is there a specific cause we know about?
Yes, absolutely. And this is probably one of the most important things to remember about Kaposi's sarcoma. It's very strongly linked to an infection, a specific virus,
Okay.
human herpes virus 8, HHV8. You might also see it called KSHV, Kaposi's sarcoma-associated herpes virus. Same thing.
Ah, okay. HHV8, the virus is the trigger. But I remember reading it's not quite that simple, is it? Like, just getting HHV8 doesn't automatically mean you get KS. There are different types.
That's a really vital point.
Yeah.
Yeah, there isn't just one type. The context matters.
Right.
And that leads to different presentations, different kinds of KS. Knowing these helps predict how it might behave.
Makes sense.
So, for example, you've got classic KS. This tends to be slow-growing, typically affects older men, often Mediterranean or Jewish background. And importantly, this type is not linked to HIV.
Okay, not HIV related. Then there's endemic KS or African KS.
Right, endemic or African KS. This one affects younger people in equatorial Africa. Often their immune systems seem normal. But it could be more aggressive than classic KS, especially bad in kids if it spreads to organs. And again, generally not HIV related.
Then the transplant link.
Yes, transplant-related KS. This can happen pretty quickly after an organ transplant. It's directly linked to the immunosuppressant drugs they have to take, weakens the immune system, lets the virus take hold.
And the one most people probably think of first.
Probably epidemic AIDS-related KS. This became really common during the HIV epidemic back in the 80s and 90s. It happens in people with HIV, particularly when their CD4 counts are low, indicating, significant immune suppression.
Right, low CD4 count being key there.
Exactly.
Yeah.
And the sort of good news part of that story is that effective antiretroviral therapy, RT, has massively reduced how often we see AIDS-related KS now, at least in people getting treatment.
But still a big issue where HIV isn't treated.
Definitely. A major problem in places with high rates of untreated HIV.
Okay. And there was another one, non-epidemic.
Yeah, non-epidemic KS. This affects men who have sex with men, but who are HIV negative. It tends to be slower, often just on the limbs or genitals.
And finally, just recurrence.
Right. Recurrent KS just means it's come back after treatment. Simple as that.
Got it. So lots of types, often tied to immune status, but not always. What do the lesions actually look like? How do they usually show up?
They often start small, like discolored patches on the skin. These can then get thicker, become plaques, and eventually they might turn into raised nodules or even tumors.
And the color. You often see pictures.
Yeah, because they involve those blood and lymphatic vessels, they tend to have that characteristic color, red, purple, maybe brownish.
And do they just stay on the skin?
Not always. They can spread. You get them on mucous membranes, mouth, genitals causing specific problems there. And yeah, in more advanced disease, they can spread to lymph nodes, even internal organs.
Okay. So HHV8 is the main driver. But we kept coming back to immune status. Let's dig into the causes, the etiology, a bit more. Is getting HHV8 always enough?
That's a really crucial point. HHV8 infection is necessary. Yes, you need the virus. But on its own, it's rarely enough. The big factor that really lets HHV8 cause trouble is a weakened immune system. Immunodeficiency.
So you could have HHV8, but if your immune system's strong, it just keeps it quiet.
Exactly that. In someone immunocompetent, HHV8 is often just dormant. It doesn't cause symptoms. It's the weakened immunity that gives the virus the chance to become active and promote KS development.
Right, that makes total sense. So, building on that, who's most at risk then if they do encounter HHV8? Who's more likely to develop KS? What are the key risk factors?
Well, number one, the biggest factor by far is immunodeficiency. That's why it's so closely linked with advanced HIV, especially, as you said, low CD4 counts, typically below 200 cells per cubic millimeter.
Mm-hmm.
And it's also why transplant patients on those immunosuppressants are at risk.
Okay, immunodeficiency first and foremost. Any other factors?
Yeah, several others are mentioned. Things like getting older, being male men are affected much more often than women in most types of KS, and possibly some genetic factors playing a role.
And background, geography, that came up with the types?
It does. Higher risk is noted for people of Caucasian, Mediterranean, Middle Eastern, or African descent. And just living in areas where HHV8 is common, like sub-Saharan Africa, Eastern Europe, the Mediterranean obviously increases your chance of exposure.
Right. And we mentioned men who have sex with men having a higher HHV8 prevalence, which links to their risk for some KS types.
Yeah. And interestingly, there's some suggestion of non-sexual transmission, too, like maybe within families. Being a spouse of someone with KS might increase the risk of having HHV8 antibodies.
Interesting.
And for classic KS specifically, some slightly odd positive risk factors mentioned were non-smoking, having diabetes, and even long-term use of oral steroids.
Wow, okay. That's quite a lot to keep track of for revision. Is there a simple way to remember the main ones? A mnemonic, maybe?
Yeah, you could try to group the big ones. We talked about immunodeficiency, male gender, age and ancestry, geography, ethnicity, maybe something like image. It's a quick
An
prompt.
image. I like that. Immunodeficiency, male, age, ancestry, geography, ethnicity. Hits the key points. Nice. Okay, let's switch gears a bit. Pathophysiology. We know what it is, who tends to get it, but how does HHV8 actually make those endothelial cells grow uncontrollably? This sounds like where it gets really interesting.
It is pretty complex. Yeah, basically HHV8 gets into these endothelial cells and it kind of hijacks the cell's machinery. It triggers abnormal cell division, makes the infected cells multiply when they shouldn't. That's what leads to the tumor forming.
And these aren't just passive lumps of cells, are they? They're actively doing things.
Exactly. The cancer cells start releasing various growth factors, and specifically factors that encourage new blood vessels to form within the tumor itself. Angiogenesis.
Ah, so the tumor builds its own blood supply.
Pretty much. It creates this dense, uncontrolled network of new, leaky vessels. Think of it maybe like an out-of-control irrigation system flooding an area. That's why the lesions look so red or purple, all those extra vessels, and blood leaking out into the tissue.
That leaky irrigation analogy works well for the color. So if you biopsy one of these lesions, what are the key things you see under the microscope?
Pathologically, the classic finding is spindle cells. These are elongated, abnormal tumor cells. You also see what we just talked about. It's highly vascular, packed with irregular, dense blood vessels, and often there's inflammation around the tumor, too.
Okay. So you see a purple lesion, especially in someone immunocompromised. KS is definitely high on your list. But what else could it be? What are the main differential diagnoses?
Yeah, this is vital clinically and for exams. You've got to think broader than just KS. Other skin cancers like melanoma or basal cell carcinoma can sometimes look similar, especially if they're pigmented.
Right, the color isn't unique.
No. And particularly in someone immunocompromised, the list gets longer. You have to think about opportunistic infections. Fungal ones, bacterial, other viruses can cause skin lesions. And conditions like cutaneous lymphoma can also present with lesions that might mimic KS.
So the biopsy is key.
Absolutely essential for definitive diagnosis. You need to see those characteristic features.
Let's zoom out again. Epidemiology. How common is KS overall? Has that changed much?
Well, in places like the UK, it's generally considered rare outside of those specific risk groups we mentioned. Globally, though, it mainly affects people with weakened immune systems, especially those with HIV/AIDS.
And you mentioned art being a huge factor.
A massive factor. The arrival of highly active antiretroviral therapy, HAART, caused a really dramatic drop in new KS cases among HIV-positive people who get treatment. It's a huge success story in HIV care, really.
So the global picture is very uneven.
Totally. Much less common now in treated HIV populations in well-resourced countries. But it's still very common in areas with high HHV8 rates and limited access to HIV treatment, like parts of sub-Saharan Africa.
Right. And historically, before HIV.
It was pretty rare globally before the 1980s HIV epidemic, mainly just those classic and endemic types we talked about.
Right.
The 80s just saw this huge surge linked directly to AIDS.
Okay, let's get practical. Clinical features. What do we actually look for when we see a patient? How does it present?
It's quite variable, depends on the type and where it is. But yeah, the most common thing is the skin lesions, red, purple, brown.
Whereabouts, usually?
They can be anywhere, really.
Yeah.
But common spots are the legs, the face, the genital area. They might start flat, like patches, then become raised plaques, and eventually those dome-shaped nodules or tumors.
Are they painful? Itchy? Do patients notice them?
Generally, the skin lesions themselves aren't painful or itchy, but they can cause discomfort, if there's somewhere that gets rubbed or if they go deeper into the tissues. And their appearance can vary a lot, different sizes, shades, often asymmetrical.
And beyond the skin.
Yeah, you absolutely have to check mucous membranes. The mouth is a really common site. Lesions there can bleed, make it hard to swallow or speak. Genital and anal areas too, especially with AIDS-related KS. Lymph nodes can get involved, causing swelling.
And the really serious internal stuff.
That's when it becomes systemic, potentially life-threatening. It gets into the GI tract. You might see weight loss, abdominal pain, nausea, vomiting, diarrhea, and pulmonary involvement in the lungs can cause a cough, shortness of breath, sometimes coughing up blood, or chest pain. Very rarely, big lesions in the throat or airways could block things off.
Okay, let's try a quick revision scenario. Imagine a patient, known HIV positive, but hasn't been great with their RT lately. Comes in saying they've noticed some new dark purple bumps on their legs and also inside their mouth. Plus, they've developed a bit of a cough and feel breathless just walking upstairs. What's jumping to the top of your list?
Right, so history of immunocompromised, the untreated HIV, the characteristic purple skin and oral lesions, and then those respiratory symptoms, cough, breathlessness. Yeah, you've got to be strongly suspecting Kaposi sarcoma, affecting skin, mucosa, and potentially the lungs too. That scenario hits several key features.
Perfect example. So, if we suspect it, how do we confirm it and figure out how far it's spread? What investigations do we need?
Like we said, the absolute definitive diagnosis comes from a tissue biopsy. You take a small sample of a lesion, send it to pathology. They look for those spindle cells, the vascular features. That confirms it's KS.
And to see if it's spread internally.
If you suspect systemic involvement, especially based on symptoms, then imaging is needed. Chest x-ray or maybe a CT scan for the lungs, possibly endoscopy if you're worried about the gut.
Blood tests?
Oh yeah, blood tests are crucial. General health check, of course. But absolutely vital if KS is suspected is testing for HIV if this status isn't known. And if they are HIV positive, you must check their immune status. That means getting a CD4 count. And also their viral load, how much HIV is in the blood. These numbers are critical for staging, prognosis, and deciding on treatment.
And testing for HHV8 itself.
You can do serology for HHV8 antibodies, shows exposure, but doesn't usually diagnose active PS disease by itself.
Got it. You mentioned staging earlier. There's a specific system for the AIDS-related type.
Yeah, the ACTG system, AIDS Clinical Trials Group. It's a way to classify severity, predict outlook. Uses three things, TI and S.
TIS.
T is for tumor extent, localized or widespread. I is immune status, specifically the CD4 count. And S is systemic illness, is there organ involvement beyond nodes or other infections or systemic symptoms like fever, weight loss.
And that boils down to 2 stages.
Pretty much. Stage 0 is good risk, stage 1 is poor risk, stage 0 means localized tumor, T0, decent CD4 count, I0, 200, and no systemic illness or visceral involvement is 0. Stage 1 means one or more of the bad factors. Disseminated tumor or visceral involvement, T1, low CD4 count, I1, 200, or significant systemic illness, S1. It helps guide how aggressively you need to treat.
Right, that clarifies the staging. So once we've diagnosed and staged it, how do we actually manage Kaposi sarcoma?
It's really tailored to the patient. Depends on the KS type, how extensive it is, their immune status, their overall health. Lots of factors.
But given that link to immunity, dealing with that is always key.
Absolutely fundamental, especially for HIV-associated KS. The most important first step is starting or optimizing RT. Getting that HIV viral load down and the CD4 count up is often the single best thing you can do.
Right.
Effective RT alone can actually make the KS lesions shrink or even disappear in quite a few patients. The sources mentioned around 40% with AIDS-related KS.
So art is the foundation for HIV patients. What about treating the lesions themselves directly?
If it's just localized, maybe a few skin lesions, you got local options. Surgery to cut specific ones out, cryotherapy freezing them off, or radiation therapy aimed just at the lesions. There are also topical creams like imiquimod or alitretinoin.
Okay. But what if it's more widespread, large areas of skin, or it's gone internal?
Then you need systemic treatment, something that travels through the body.
Hmm.
First-line options mentioned are things like liposomal anthracyclines, that's a type of chemo packaged smartly to target KS better, or systemic interferon alpha, which is an immunotherapy.
Other option.
Paclitaxel is another chemo drug sometimes used. And radiotherapy can sometimes be used more broadly or for specific problem areas if chemo isn't tolerated well.
Is KS usually cured by these treatments?
Generally, no. The sources describe it more as palliatively controllable. The aim is to manage the lesions, control symptoms, stop it progressing, and improve quality of life. And crucially, restore immune function if possible.
You mentioned something earlier about starting ART or sometimes making things look worse initially. Iris.
Yes, that's really important to remember. Immune reconstitution inflammatory syndrome IRIS. Sometimes, when you start ART in someone with advanced HIV and KS, their immune system starts recovering, which is good.
Right.
But as it recovers, it can suddenly see the KS again and mount a really strong inflammatory attack against it. Paradoxically, this can make the lesions flare up quite dramatically for a while.
So what do you do then? Stop the ART go?
No, absolutely not. You continue the ART because that's the long-term fix for the immune system. But you often need to add chemotherapy temporarily just to control that KS flare during the IRIS phase.
Wow, okay. Complex. Requires a team effort, I imagine.
Definitely. Managing KS, especially with HIV, usually involves HIV specialists, oncologists, dermatologists, maybe radiation oncologists.
Yeah.
A multidisciplinary team approach is best.
So looking ahead then, prognosis. What's the general outlook for someone diagnosed with KS?
It really varies a lot. Depends on those factors again. Localized disease naturally has a much better prognosis than widespread disease, or if it's affecting internal organs.
And for HIV patients, the key factor is?
The response to ART. That's the single biggest thing influencing long-term outlook in HIV-associated KS. If ART suppresses the virus and the CD4 count recovers, the prognosis is dramatically better than it was before RT existed.
So outlook really hinges on controlling the underlying cause, how widespread it was at diagnosis, treatment response, and risk of it coming back.
Exactly. And interestingly, the sources noted that we don't fully understand how KSHV spreads, and having high antibody levels might, counterintuitively, be linked to higher transmission risk and maybe developing more aggressive organ involvement. Still things to learn there.
Lastly, complications. What can go wrong? What do people need to watch out for?
The most serious thing is spread to internal organs. That can lead to organ dysfunction, even organ failure. That's potentially life-threatening.
So the disease itself can cause major issues if advanced.
Yes, significant morbidity, potential mortality. And treatment itself can have side effects, complications from chemo or radiotherapy.
And these patients are often immunocompromised anyway.
Exactly. So they're already at higher risk for other opportunistic infections or even developing other types of cancer. So close monitoring, managing their overall health and immune status long-term is really vital.
Okay, so let's try and summarize. We've taken a really detailed look at Kaposi's sarcoma. We've covered the definition, the different clinical types, classic, endemic, transplant, AIDS-related, non-epidemic, the absolute crucial link to HHV-8 infection plus immunodeficiency.
Yeah, we hit the key risk factors. Remember, image. Immunodeficiency, male, age, ancestry, geography, ethnicity. We talked about the pathophysiology, those spindle cells, the crazy blood vessel formation, angiogenesis.
Right, the leaky irrigation system idea. We looked at the clinical features, skin lesions, mouth, genitals, lymph nodes, and the serious internal organ involvement, how to investigate with biopsy, imaging, and those vital HIV tests like CD4 and viral load.
Then the staging, ACT-GTS staging. And the management, how critical ART is for HIV patients, local therapies for limited disease, systemic chemo or immunotherapy for widespread KS, and remembering that tricky IRIS situation.
And finally, the variable prognosis hugely improved by ART in HIV, and the potential complications like organ spread or other infections. It's a complex condition, but hopefully breaking it down like this helps for revision.
Definitely. The key takeaways really are that HHV-8 plus immunodeficiency equals risk, the varied presentations, and the absolute importance of managing the underlying immune problem, especially initiating and maintaining ART in HIV.
And reflecting on it, the impact of ART on AIDS-related KS is just incredible, isn't it? How a therapy targeting the underlying immunodeficiency transformed the outlook for a specific cancer. It really makes you think about future possibilities for other virus-linked cancers, if we can understand those interactions better.
It's a powerful example of progress, for sure. Lots still to understand, but yeah, a hopeful one.
For more free MSRA revision resources, definitely visit freemsra.com. And for the full premium revision toolkit, you can head over to passmsra.com.